Good afternoon, everybody, or good morning. I believe my friend David Jefferson from Washington State is on the phone and on the webinar, and so it would be morning for you, David. Thank you for joining. Thanks, everybody, for joining. I don't want to spend too much time. Of course, I'm going to talk about our Georgia Basics program. We were a SAMHSA-funded site, and our program officially ended last September 31st, and so, or excuse me, September 30th. We did get some no-cost extension dollars, and we're doing a variety of analysis on the data that we gathered, and that's an ongoing piece of sort of the end of our grant, and that will be going on for the next year, and so hopefully I'll have an opportunity to come back on and share some of that more recent data with you. I don't want to spend too much time really talking about sort of giving you SBIRT 101. I'm going to assume that most of you are somewhat familiar, even if you're not doing SBIRT, that you're somewhat familiar with the concept of substance use screening, brief intervention, referral to treatment, and that you have some idea of sort of the parts and pieces of SBIRT. I will say, and I think this is a very important distinction, that SBIRT is not a substance use initiative that is conducted in healthcare environments. SBIRT is a healthcare initiative that focuses on substance use. And so I think, again, that's a really important distinction, that when we talk about SBIRT and we talk about our model, we use a public health model, and we approach substance use as a public health issue. And so we are really in the business of health behavior change. And we're not focused on substance use as a criminal justice problem or a social problem or any of those other ways that we might categorize substance use. We really want to focus on the healthcare aspects. So we think about SBIRT as a healthcare initiative in that focuses on substance use. Initially, let me say thank you to all of the partners in the Georgia Basics project. Certainly the Substance Abuse Mental Health Service Administration Center for Substance Abuse Treatment. They were our grant funders. We received, well, I got a slide for that, so I'll just skip that. Grady Health Systems. Grady Health Systems is the largest public health hospital in the southeast. There's a picture of the giant monstrosity that is Grady. That's the main hospital there. It's you can tell it's sizable. I worked at that time for the Department of Behavioral Health and Developmental Disabilities Division of Addictive Diseases. We were the folks that were tasked with managing and implementing the grant. Georgia State University did our evaluation and follow-up, and continues to work analyzing our data and writing reports and publishing papers. And then, of course, the Medical Center of Central Georgia, which is the second largest hospital system in Georgia, located in Macon. For you music fans, that's the home of the Allman Brothers. And so those were Grady Health Systems, Medical Center of Central Georgia, our two primary clinical sites. I also want to say thank you to Dr. Gabe Coopermink, who's the chair of the Department of Community Psychology at Georgia State University, and his fantastic evaluation team. They've done an amazing job, and really grateful to them for all the work that they've done, and also Dr. Aaron Johnson and the evaluation folks down at the Medical Center of Central Georgia. Again, the data that we've compiled and the ability to analyze that data, and the papers and presentations that both Aaron and his team and Gabe and his team have done has been really exceptional. So a quick overview. Ours was a 5-year cooperative agreement with the Substance Abuse Mental Health Service Administration Center for Substance Use Treatment. We received $2,520,000 per year to design, draft, implement, and then hopefully sustain SBIRT services in the state of Georgia. And so that was a total of $12,600,000 of your tax dollars actually at work, hopefully doing good things. Real quickly, our administrative structure. Again, these dollars came through the Office of the Governor, down through the state of Georgia, Office of Addictive Diseases. You can see our primary contractors were Grady Health Services, where we did patient care, Medical Center of Central Georgia, where we did patient care, and then Georgia State University was responsible for our evaluation and follow-up. We also had some other folks that supported us in our grant. MSTAR Research was a consultant on the grant. The Multicultural Development Institute did our cultural sensitivity training and was a partner and worked closely with our providers on issues of cultural sensitivity and working with the various cultures that we worked with. And then River Edge Behavioral Health Center down in Macon was also our primary referral for patients that needed higher levels of care. Again, a little bit more about our clinical sites. Grady Health System in Atlanta. Again, it's the largest public health hospital in the Southeast. They have more than 200 specialty and subspecialty clinics, so everything from heart specialists to community clinics. I mean, a really broad array of services and serving, hundreds of thousands of people a year. Grady is a national recognized emergency department and a level 1 trauma center. In Atlanta, or in fact in Georgia, we always say if I'm in an accident, take me to Grady. It's an exceptional trauma center. It's also a teaching hospital for Emory University and a Morehouse College of Schools of Medicine. Medical Center of Central Georgia, as I mentioned, second largest hospital system in the state. Again, multiple specialty and subspecialty clinics. They are also have an exceptional emergency department. They're also a level 1 trauma center. And they're also a teaching hospital for Mercer University. Some important caveats about our population that we saw. About 40% of our patients were precariously housed. And when we use the term precariously housed, we mean that they were couch serving, they were homeless, they were in shelters, they maybe had SRO accommodations, then they would be in jail, then they would be homeless, then they would be couch surfing. And so really sort of transient and again what we termed as precariously housed. As you can imagine, that made complicated our evaluation process significantly. We're required on this grant to follow up on 10% of all the patients who score a brief intervention or above. And so we did have some difficulty accessing patients post their care and for our follow-up because of their housing situations. And also, many, if not most of our patients had complex health care conditions, and certainly lack of consistent health care. We know that from a variety of things, not only from the patient records directly and from their medical records. We also know that from the fact that they would frequently use the emergency room as their primary care provider, that most were not insured or poorly insured or underinsured. The Affordable Care Act had not come into play prior to the end of our grant, so maybe that condition has helped a little bit, but certainly multiple complex healthcare conditions, and I'm sure, as you know, that since many of you work in addictions, that substance use can either cause or exacerbate health conditions. And the expectation, of course, of SBIRT is as people start to address their substance use, and not necessarily dependent use, but just even high-risk use, that their healthcare outcomes should improve. So I want to talk just a little bit about our clinical structure. This to me is probably the most important thing about SBIRT. Very important for us for any number of reasons, not only good patient care, but also for third-party payers, that we have some fidelity to an actual evidence-based model. Clearly, when we do substance use screening, brief intervention, and referral to treatment, we use valid and reliable screening tools. In Georgia, we were required by the grant to use the ASSIST, and we use the ASSIST, which is a World Health Organization developed screen. We used version 3.1. Here in Ohio, in my new project here, and also around the country, most sites have used the Alcohol Use Disorders Identification Test, the audit, and the Drug Abuse Screening Test. And so those are the tools that you generally see, and they are valid, reliable tools that will capture the information that we want and adequately identify the patient population that we want to intervene with. You also notice that we did pre-screening, and most sites do. The object of the pre-screen is really to rule out patients that don't need service. So it's a way within 30 seconds to rule out generally around 75% of the population. If you look at most of the literature, large epidemiological studies, other literature that's out there, and certainly the information from most of the SAMHSA grant-funded states over the last 10 years, what we see is about 25% of the population will score positive on the pre-screen. Our pre-screen questions, the NIAAA pre-screen questions, is basically, this is a paraphrase, but basically the question is, if you're a man, have you at any one time in the last 12 months had 5 or more drinks on one occasion? If you're a woman, we ask the same question, except it's 4 or more drinks. Then we also ask a substance use question. At any time in the past 12 months, have you used recreational drugs or prescription drugs other than how they were prescribed by your physician? And those are, again, rule-out questions. We'll generally rule out about 25% of our population. In Georgia, that was very consistent. Week in and week out, we were always between about 23 to 28%. So right around that 25% mark. Those questions were conducted by the nurse at triage, so as part of the patient intake, which means we ask this question to all of our patients. So this is really the universal screening part of the project. If we frame this in sort of a medical analogy, this would be like a blood pressure. When we go to the doctor, we always get a blood pressure, and a blood pressure is merely a universal screen for hypertension. It doesn't diagnose anything necessarily, but it gives an indication to the doctor that there may be a problem, or there may be cause for concern, or there may be reasons to intervene and at least gather more information to make some decisions about the issue of hypertension. And that may lead to a referral to a cardiologist. It may not. It may lead to a brief discussion about blood pressure, its causes, high blood pressure, its causes, and behavioral changes that a patient might make to deal with that. And so we really think about the universal screen or the pre-screen as we frame it like a blood pressure. In Ohio, we talk about it as the 5th vital sign. So we were pre-screening about 2,500 patients a week at our 2 sites, so a really massive number. If patients scored positive, and again about 25% of the patients will, then our staff would be notified through the EMR, the electronic medical record, that there was a positive pre-screen. They would access the patient. At that time, they would do the full screen, which for us was the ASSIST, and then also required by the grant to do a significant amount of other data gathering for the Government Performance and Results Act. Those of you who have worked in addictions and have worked with federal grants are familiar. If you've worked with ATR or other such grants, so you're very familiar with the process of GPRA. And then, of course, we're required to upload that data to the federal SACE system. Our health education teams were employed by the sites. There's some benefits to our staff being employed by the sites, not the least of which is they have access to the patient medical record. So we were actually able to develop at our site in Macon an actual SBIRT tab in the medical record where we could go in and record the screening score, drugs of choice, do a short chart note, and that would become a part of the permanent medical record for the patient. Questions always come up about 42 CFR Part 2. For those of us who are in the addiction field, we're extremely familiar with 42 CFR Part 2. Doctors aren't, and medical staff generally aren't. Obviously, they're very familiar with HIPAA. Those of us, again, who work in addictions know that 42 CFR Part 2 is significantly more strict than HIPAA is about confidentiality in patient records. SBIRT is not considered a form of treatment. If you look at the language in 42 CFR Part 2, it will say that any information that's gathered for medical purposes as opposed to treatment services is not protected by 42 CFR Part 2. And so in the sense that we're merely gathering information for medical care, the information that we gather is not necessarily part or not necessarily under the rubric 42 CFR Part 2. Now clearly if we refer a patient to community treatment, then 42 CFR Part 2 comes into play. We need releases for that, etc. But internally, when we think about SBIRT, important to recognize that our goal in SBIRT is to make substance use screening, brief intervention, and referral to treatment a standard practice in medical facilities. As such, we do not consent patients for this service. Again, if we frame this as a medical analogy, when you go to your doctor, they don't continue to reassess or reconsent you for every service that you get. If you get a flu shot, they don't have you sign another consent form. If you go to radiology to have your ankle x-ray, they don't give you another consent form. If they put a bandage or give you a stitch and a band-aid, they don't give you another consent form. And the idea here is that when you go into a facility, you sign the HIPAA information, you agree to the services, and you're not reconsented repeatedly for every sort of piece of medical care that you get. And we understand SBIRT as a healthcare initiative in the same way, and so we don't consent patients just to receive screening and brief intervention. Certainly if we're referring out, we want to be able to talk with the community provider, and then we would. You can see that about 32% actually that little piece of the slide is wrong, and so I'm going to skip that. So we do a full screen, and the full screen can also be another area of rule out. What we find is, and actually I take that back, this piece is right, about 32% of the patients that we would give a full screen to would also rule out. So they would not meet the threshold for a brief intervention or something higher. So that's conducted again by our health education staff. Then those patients that score at least at the brief intervention range or higher, everyone would get a brief intervention no matter where they scored. Brief intervention provided by the same health education staff, so there's no handoff here. They do the full screen, they do the GIPRA, then they do the brief intervention. Again, no handoff. About 54% of every patient that we screened would score in the brief intervention range. So we would have the audit cutoff score. I believe our cutoff score was 8. Anybody that was 8 or above would naturally get a brief intervention. We also did a brief intervention with any patient that reported positive on the single question drug pre-screen or universal screen. So about 54% of our patients were moderate risk. Those patients would get a brief intervention. The goal of that brief intervention is not necessarily abstinence, and it's certainly not referral into a higher level of care. The assumption is that patients who score in this level are at risk for psychosocial or healthcare problems based on their current substance use choices, and that our goal would be to help them understand what safe limits are, particularly for alcohol use, or what low-risk limits are for alcohol use, and assist them in potentially making health behavior changes around their substance use choices that would take them from moderate risk to low risk, and that's fairly easily accomplished, believe it or not. For instance, if a patient is drinking 6 beers at one sitting, then for a man, a healthy man under 65, that means they're 2 beers over what we would consider a low-risk daily limit. And so if that patient can just not drink 6 but drink 4 in a sitting, then they've moved themselves into low-risk limits. And so our goal of that brief intervention really is to educate the patient about what low-risk limits are, inform them of where they're at as far as risk, certainly talk about healthcare risks and other psychosocial risks based on their current use patterns, and then if they're willing to assist them in making behavioral changes that would reduce that risk. As you can see, about 7% of our patients would score in what we would call the brief treatment range. We trained a specific subset of our health educators, and these folks were master's degree and above folks, to conduct brief therapy. So we could refer back internally to ourselves. We chose that model for a number of reasons. First of all, if you look at research, it says that a patient is more likely to return to a place that they've been to before. And if you think about that just anecdotally, it makes complete sense. If a patient knows where a facility is, where to park, how to get in the front door, they have some sense of familiarity, familiarity and comfort with that site, and it reduces their anxiety. They're much more likely to come back. And not only that, but frequently they would see the same providers gave them the brief intervention. And so those folks could come back for up to 12 sessions, and these are really extended brief interventions. We would spend 45 to 50 minutes with them, working specifically on assisting them in motivating them towards change, supporting them, planning for change, providing a menu of options, and assisting them in making, again, health behavior change around their substance use. And lastly, about 7% of all of our patients that we screened that received the assist screen. These patients were very high risk, and we would call them likely dependent. I think another real important thing that's a caveat about SBIRT is that we are not in the business of making a diagnosis. If we go back to the blood pressure analogy, a blood pressure doesn't diagnose anything. It merely is an indicator, a screen for hypertension. It indicates potential problems. And so if your blood pressure is so high that your doctor assumes there is likely a cardiac problem that's diagnosable, they will refer you to a cardiologist for additional tests. They generally are not going to make a diagnosis of chronic heart disease in a primary care office. They're going to refer you to a specialist. That's our model as well. When we find people who are likely dependent, and we don't know that they are, we don't do a diagnosis, but their screening implies that they are very high risk and likely dependent, then we want to refer them to community-based providers. The old model of referral, I think I know when I was going to school and first came into the field 29 years ago, the old model was really, well, if the patient wants it, they will figure out how to get it. And of course, the new model says we will do everything we can to remove barriers and build bridges. And so we would go out of our way. We would, for instance, if a patient is likely dependent and they are willing to access traditional care in the community, what we would do is we would have them sign a release, a 42 CFR Part 2 consent form. At that point, we would call the treatment center, and we would say, I'm here with Bob Smith, and I would like to send Bob over for an evaluation and a treatment plan. And they would say, great. And so we would, and if we needed to give them cab fare or bus money to assist them in making that transition into the community provider, we most certainly would, because again, our goal is we recognize that anything that gets in the way of the patient engaging is problematic. And so anything we could do to create a smooth conduit into care, a smooth transition from medical practice to the community provider, we would go out of our way to make that as smooth as possible and as easy as possible for the patient to increase their likelihood of engagement. And so that's really sort of how our clinical structure looked. I want to talk about fidelity, and I mentioned this earlier. Fidelity is really vital for a couple of reasons. First of all, we are engaged in an evidence-based practice. We're engaged in an evidence-based practice if we actually do it properly. And third-party payers particularly are very concerned that that our practices aren't necessarily evidence-based, or that we don't have a lot of fidelity to the evidence base that our practice is built on. So for instance, we use valid, reliable screening tools. Most third-party payers are comfortable with those tools. They know what those tools are. They recognize that they're valid, reliable. And so we don't run the risk of a substance use screen becoming something like a medical provider saying, "So, Jim, are you drinking?" And then charge the insurance company $40. We're trying to avoid those kinds of problems. Or on the backside, that a brief intervention becomes something like, "You know, Jim, you're drinking too much, you need to stop." And now we bill the insurance company $60. And so the whole idea here is that we have some fidelity to practice, and that requires training. And it also not only requires training, but it requires additional follow-up with provider staff to ensure that not only do they understand the evidence base of using valid and reliable screening tools, but also the evidence base of motivational interviewing, and that they have some skill in motivational interviewing. So the way we worked around the issue of clinical fidelity is, first of all, with all of our provider staff, and these are health educators, bachelor degree and above primarily, we give them 16 hours, so 2 days of motivational interviewing training. They would do, during that time, not only get an overview of MI, but have an opportunity to practice their skills, to work in small groups, to do role plays, to watch videos, a variety of different things to get them thinking in the MI spirit. Subsequent to that, when we turned our staff loose in the wild to see patients, we audio recorded with the patient's consent every session. So if they did 8 sessions a day, they made eight audio recordings of those sessions. Those sessions then were uploaded to a secure website, and one of those once a week, one of those sessions would be just randomly selected, and then we had motivational interviewing network of trainer coaches then who would listen to these tapes and code them, and that's the evidence base for motivational interviewing. When we talk about MI and coding, we can tell if a provider understands and is using motivational interviewing. We can listen to an audio recording and know how many times they're asking open-ended questions, how many times they're asking permission, how many times they're doing a complex reflection, how many times they're summarizing, how many times they're asking for permission to offer advice. We can actually get a number, and gives us a very good evidence base of their ability and their the efficacy in their competency in using motivational interviewing. So we would then, pull out a random selection that would be coded, and then there would be phone coaching. One of our coaches would call our health education staff, and they would spend 15 to 30 minutes talking about the process, talking about skills that needed to be enhanced, ways to improve. That, of course, over time led to improved competency. And we did a model where initially we would listen to tapes weekly. Then as people moved towards increased competence, every other week, then monthly, then quarterly. And so what we did over time is not only were we able to improve the competence of our staff, but then when our staff became proficient, then they could become coaches. And so that they could help new staff, they could listen to each other's tapes and do coding, and we taught them how to code. how to coach, and things like that. And so again, the goal here, besides clinical fidelity, the goal is to build a workforce that is competent with the skills that they can then take forward, move forward, and use in other environments, but certainly bring to bear on patient care. And so again, I can't stress enough the need for fidelity to the evidence-based model. And there are a variety of ways to accomplish that. This was our model. We found it very productive. By the end of a year of being coached, we had the competency of our providers was exceptional. And although there's not a lot of data on this that I see, not a lot of research, but my assumption would be is that the higher the competency level of the person who's doing the intervention, the more likelihood there will be that leads to positive behavior change for the patient. I mean, that just seems to be a no-brainer, really. So focusing on competency and the evidence base, I think, is really vital to successful SBIRT. Here's some important caveats from our program for those of you who are thinking about developing programs. And again, we're in 2 very large hospital systems. These things change depending. For instance, in our Ohio project, we're currently in 3 FQHCs, so they're basically 9 to 5 operations. But in our Georgia project, our staffing was 24 hours a day, 7 days a week. Sometimes we would have multiple staff on the floor, sometimes 1 staff, depending on time of day, patient flow. For those of you who are thinking about initiating SBIRT either at a clinic or at a hospital, one of the first questions that you want to ask is, what is the unduplicated patient count? How many patients are likely going to come through the front door in a week or a month or a year? Then you can do some quick math to figure out how many patients are probably going to need a brief intervention or referral to treatment, et cetera, based on that 25% positive mark that we generally see. And then a second thing you want to know, particularly if you're implementing in a 24-hour operation, is when are the peak times, the peak days, those kinds of things. And what is the patient flow like? How long does it take a patient from the time they walk in the front door to walk out the back door? How long is the patient actually on site? Because that gives you then some ideas to plan for. It could be some budgetary planning. It certainly is human resource planning. But it also gives you some idea of where are points in the process where SBIRT can be done without disrupting the other providers that are taking an X-ray or giving a shot. All of our health education staff wore scrubs. They were located in the emergency department and in the trauma center. If you ever go to a hospital or a trauma center, you'll see that in most hospitals, all the staff are color-coded based on the color of their scrubs. So doctors are green, and nurses are blue, and so our health education staff wore black scrubs, and that identified them as SBIRT staff. Number one. Number two, it helped identify them as healthcare staff. What we found is if they walked in business attire, they did not look like health staff, and they were immediately, if not suspect, because they didn't look like healthcare staff, it didn't appear as though they were providing a healthcare service. So we really encourage sites to think about how their staff dresses. If the doctors wear lab coats and the nurses wear scrubs, have your SBIRT staff wear lab coats or have them wear scrubs. Because it makes a difference in how they're perceived by the patient population. And again, because we're doing health care, we want our staff to appear to be health care providers. And so scrubs, lab coats, et cetera, can really make a difference in how they're received and how the information is received by the patient. Georgia State University, as I said, conducted our follow-up and evaluation. We were required, of course, because of our grant funding, to do follow-up with 10% of our patients, as I noted earlier. This is very important, though. If you're doing your own SBIRT project, it's very important that you capture some data for any number of reasons. If nothing else, you want to show that it's being both efficacious in regards to improvement in overall health outcomes for your patients, but it also can be nice to be able to look at cost savings, cost avoidance, or cost generation if you're billing for these services. And so doing some kind of follow-up, how many of your patients actually score positive? How many patients appear to have a substance use disorder? This is very, important information that can really help you craft and shape and mold your program and do quality improvements as well. But for ours, because we're grant funded and Georgia State University was working with our sites to do follow-up, we assigned a liaison from Georgia State University to work directly with each clinical site. And that our staff from Georgia State would be well versed in GIPRA, in data collection, in follow-up, and all those things, and then could work directly with the sites or the staff at those sites to ensure that we were gathering the data correctly, that the GIPRA was being gathered appropriately, that our follow-up tracking forms would be completed, and those kinds of things, and resolve any kind of data collections issues that might occur. Another thing we did, and those, if any of you are from grant-funded sites, we also contacted our follow-up patients after 7 days to verify their information. So basically, when we engaged them in follow-up, we also incentivized follow-up. And we would tell them if we can, and remember 40% of our population was precariously housed, we would tell them we would get a variety of contact information, website, or email addresses, and phones, and where they're staying, and the number at the shelter, and could go on, and where their grandmother's phone number. And then we would try to contact them a week later. If we were able to contact them and verify the contact information, we would provide them a $5 gift card. And then we would let them know at that point that we were going to follow up again with them in about 6 months. They'd receive another call, and if we could complete that call, we would give them another $15 gift card. An interesting, very down-in-the-weeds caveat. When we initially started doing our follow-up, we had an abysmal follow-up rate, down around 40%, 35 or 40%. And we couldn't understand why we weren't able to get a hold of people. They just wouldn't answer the phone. And at some point, one of our sharp grad students, I believe, realized that when Georgia State University called a patient's cell phone or home or whatever it was, the caller ID said, State of Georgia. And people would look at that caller ID and say, I don't think I have any business with the state of Georgia. And they wouldn't answer the phone. And so we actually had to go through the rigmarole of having the caller ID changed to say Georgia State University. And it was amazing how just that small change assisted us in actually being able to do patient follow-ups, because we would tell them Georgia State University is going to call, and we're from Georgia State University, and Georgia State University is going to do our follow-up. So when they saw Georgia State University on their phone, they weren't surprised, and they would answer the phone. So interesting little aside for those of you who are potentially doing patient follow-up, and if you're grant-funded and calling from state offices, that's something you might want to check. So at this point, let's stop for just a minute. Does anyone have questions? Chris, can they type in their questions, or?
Yeah, I don't have any questions or comments yet.
Okay, well, we'll give them we're going to give you 30 seconds while I have a drink of Starbucks here to shoot a question if you have one. David, I see you have a question. At least there's a question mark by your name there.
Yeah, he says you mentioned GIPRA. How did that go?
Oh, GIPRA may be in the top 5 of the worldwide most onerous tasks. And any of us who have done GIPRA recognize that it's vital to funding. This is the information that goes to Congress. that drives funding for SAMHSA and other initiatives. And so from that perspective, it's necessary, and it's also can be good data for us to analyze and look for trends and information on our patients. It's terribly onerous. We work a lot with our provider staff on how to do the GPRA, how to use motivational interviewing as their approach when they're providing GPRA. How to make it less difficult with the patients and less difficult with themselves. We very seldom had anybody refuse to move forward just because of the GPRA questions. One of the things that we've learned doing SBIRT and doing follow-up and doing GPRA is you can actually rely on most people's altruism. And what I mean by that is we would one of the sort of standard lines for introducing the GPRA is, I'm going to ask you a number. I'm going to ask you a number of other questions. This is going to take us probably 10 or 15 minutes, and and what this does, it helps us gather information that may be helpful nationally as we try to improve our program and try to improve other programs. This could be really helpful and really potentially impact, thousands and thousands of people around the country. It may not help you, but it really may help others. So are you okay with that? And what we found is when you present it that way, a lot of times patients are much more willing to sort of go through this process because they feel like they're giving something back. And so you can actually rely on a patient's altruism to want to be helpful and to be a partner in gathering this data. So it's time-consuming. The good news is when programs sustain, GPRA is not necessary any longer, and so that piece of it goes away. It's a necessary evil that we face every day. We get it done, and providers get better and better at answering these questions and feeling more comfortable with the information, which is also really important. We all know about limbic resonance, that if I'm uncomfortable, my patient will pick up on me being uncomfortable. And so the more comfortable my providers are with, or your providers are with asking GPRA if you have to, or if you are grant funded, then the more likely the patient will be comfortable with the process as well. And a lot of times it's just the process of doing, repeated GPRA questions with the patients until the provider gets comfortable, and then that process gets easier for both the patient and the provider. Now, is there other questions?
Yes, there are others coming in. How did you determine that you had reached as many people as you set out to, therefore shutting down the screening part of SBIRT?
Well, we obviously kept all that data. Clearly, if you're grant funded, then when you do your initial grant application, you set some targets. And that's really sort of a shot in the dark. You make a guesstimate of how many patients you think you'll see, how they will break out across screening and feedback, brief intervention, brief treatment, and referral to treatment, which are the 4 categories that we use. And it's really kind of a crapshoot. It really is. And so what we do is we track, every patient that gets a pre-screen, that would be noted in our EMR, and so we could access that data. And that's where the bulk of the data really is patients who get that pre-screen that are negative. And again, if we ask 100 patients a pre-screen question, our expectation is that 75 of them will be negative. And for us, from a GPRA standpoint, that means we only do GPRA Section A, which is demographic. Most of that information we've already gathered from the patient because it's in their EMR. And so we would just get that data out of the EMR. There may be some questions that aren't in the EMR, particularly if you're doing GPRA A, the military questions. So there could be some disconnect there. But by and large, because GPRA is driven, the sections of the GPRA you do is driven by score. And we would just track that through. And then, of course, we also, for instance, here in Ohio, we're doing everything electronically. Currently, we have an interim software loaded on tablets, that has all the screening questions, all the GIPRA questions, and then that gets uploaded to a state server that then gets uploaded to the federal server. In the next few months, we're actually developing an almost completed development of just an SBIRT-specific data gathering tool that will be loaded on tablets. And so our staff will be not only mobile, but they will enter everything on tablets, which makes it significantly easier. And that data will immediately, when they push completed, that data will immediately upload and disappear from the tablet. So we don't have any concern about that data being compromised or getting, you know, violating HIPAA or 42 CFR Part 2 or anything like that. That data will just disappear, and of course it's encrypted and all those things. So that's how we then can keep that accurate count from the GIPRA perspective.
Okay, here's another one. At what point in the health at what point is the health educator brought in, and how are they handed off?
At our sites, we were able to, let me talk about our Macon site because I think this was really cool. If a patient came in, the nurse would do, the triage nurse would, the pre-screen was loaded into the EMR, and so it was just part of the standard questions that a person would be asked at intake. Why are you here? What medications are you using? Who's your insurance company? What's your address? How much are you drinking? They would get those pre-screen questions. And if they were positive, when the nurse clicked on a yes answer to either any of those pre-screen questions, a little icon would light up in sort of the, you know, just it sort of looks like a Word program or a Microsoft program where there's a menus across the top. We would have just a little icon that looked like a person would light up, and that would and our staff would be looking at the EMR and say, oh, there's, you know, the SBIRT button just lit up next to Mary Smith. And so then that would activate them to go see Mary Smith. And all they would know at that point is that there was a positive pre-screen. And they would go in then when Mary Smith was put in a bed or in the treatment room, they would go in and say, hi, Mary, you know, I'm Steve O'Neill, and based on some of the questions that we asked you at intake, I've got the doctors asked me to do some follow-up with you. And so then we would ask the audit questions or the DAS questions or whatever was indicated based on the positive pre-screen. And then the GIPRA, and then the brief intervention and any other service that we need to provide. So that was all done as a piece. And so really the only place where there's a handoff is from the triage nurse asking those initial pre-screen or universal screening questions. That icon lights up, that it notifies our staff that they need to go ahead and access that patient. So it was actually a pretty smooth process.
Can a layperson effectively use the SBIRT as in a military organization? We would like to use a quick audit tool that could either be used by squad or team leaders or for self-assessment. Is there any way SBIRT could fill this need?
Absolutely. In fact, there's a number of grant-funded programs right now that are working with, particularly with National Guard. Iowa has an exceptional program, and I don't have Michelle Tawada's contact information, but she has an excellent program, and I'm sure we could get you that information. In fact, it's probably on the SAMHSA website under SBIRT grantees. So Iowa's doing an exceptional job. South Carolina is also working very closely with their National Guard doing SBIRT. I think their model, there's some differing models out there. I also worked actually with the National ATTC and Holly Hagel there and with Christine Pond to develop a SBIRT project for Louisiana National Guard. So there's a lot of interest in working, particularly with the National Guard. There's a variety of different models out there, but people doing some really good work. So the answer to the general answer is yes. These tools can be used by, I mean, there's a modicum of training clearly that needs to happen, but clearly squad leaders could do this. And there's ways to integrate this into particularly things in the National Guard. For instance, I know the Iowa model, because as you know with the Guard, it's 1 week end of month, and 2 weeks a year. And so when they come in for, I believe it's for their 1 week or their 2 weeks a year, the first thing they go through is a big health screening. It's part of their health screening. And so if they are identified as being at risk, then a brief intervention happens, potential for referral, and all those kinds of things. So again, there's some good models out there. There's more and more we're working. I really want to encourage you to look at and if you can contact the grant folks in South Carolina or Iowa. They're really doing some great work right now. And I know they'd be thrilled to support any kind of initiatives that you have, or if you have deeper questions that I can't answer today. And certainly I would be happy to hear from you as well. So anything I think that we can do to be of support, I think you'll find the other grant sites very supportive and more than willing to talk about what they're doing and to provide some technical assistance for you if this is something you'd like to move forward with.
What percent of positive pre-screens are not actually screened using the assist?
Would you say that again, Christine? I'm sorry.
What percent of positive pre-screens were not actually screened using the assist?
That is an excellent question. We were unable to see all of the patients that scored positive just because of the numbers. Now, that's a good news, bad news. From the good news perspective, it gives the provider site some idea of the unmet need. And so questions of staffing, questions of budgetary considerations for staff, those kinds of things then come into play when you're saying, there's a number of patients that could benefit from our service, but we're unable to provide it because we're understaffed. That's sort of the good news. The bad news is the patient isn't getting a service that they would likely benefit from. So I would guess, and I'm just going to have to go with sort of the raw data in my head, and I'm sure I could find an exact number for you, but I would guess over 25% of everybody we screened. So, well, let's take Grady Health Systems. We were screening about 2,000 patients a week at Grady, or so, somewhere between 1,500 and 2,000. So let's use 2,000 as a round number. That means 500 patients needed a full screen. And we probably saw 250 of those patients, maybe a little more, maybe a little less. So maybe half of the patients who probably would have benefited from a full screen and a brief intervention or something additional, we were unable to provide those services just because of inability to have enough staff to meet the need. Excellent question.
Is it typical to have most people who screen in the BI/BT range unwilling to engage any further? Anecdotally, my patients are agreeable to engage and are extremely polite but never return for follow-up. What has Georgia done to address this, if this is the case?
Yes, actually I have a slide later about we were remarkably good, particularly at our site down in Macon, Georgia, in assisting people in accessing care. And so I actually have a slide about that. I don't think we had, generally patients would not be resistant to brief intervention. Very small percentage people would say, I don't want to talk about it. Probably 1 or 2%, I mean, very small. As far as patients in brief therapy, one of the things about brief intervention, and I think, again, I don't think I mentioned this, but it's very important, the brief intervention has different goals depending on a person's score. So if a person is in that moderate risk range where we assume they're not dependent, they don't need additional services in the community, they don't need to be abstinent necessarily, then we are going to work with that patient to help them understand that they are at risk for psychosocial healthcare problems, help them educate them about what low-risk limits are, and then work with them to make, and in just a very few minutes, to potentially make a plan to reducing their use. And a lot of times it's amazing, but that's actually quite easy those of us who work in addictions are used to working with a very chronic, very ill, very dependent population for whom change is incredibly hard, particularly change around substance use. They've lost control over their ability to moderate their substance use. We don't anticipate that that patient population is going to be able to become a controlled drinker or a controlled user, that abstinence is likely the only low-risk choice for that population. But most of our patients are not in that population. Most of our patients are in a moderate risk range where they have not lost the ability to moderate their use. And frequently we find that patients are drinking over what we would consider low-risk limits, or what the NIAAA would consider low-risk limits, and they don't know that they're drinking over those limits. And merely the presentation of new information will lead to change. That they'll go, oh, well, I had no idea. I drink 6 beers usually when I sit down and watch a game, but I'll just drink 4 from now on. And they make that change. So they've cut their use by 1/3 or 1/4. They've moved from moderate risk to low risk, and it's real easy. And so that's part of what we find, again, as we approach this as a healthcare initiative. We identify that we educate them about what risk they're at and what they can do to make some changes around their level of risk. And patients are remarkably open to making those changes. So working with the brief intervention population is generally fairly easy. For brief therapy and referral to treatment, our goal of a brief therapy session would be to encourage someone to certainly moderate their use because they're at risk, and try to motivate them to come back for additional services at the brief therapy level. Sometimes we were successful, sometimes not. It's completely up to patient choice, obviously. Then the referral to treatment group, those folks that are likely dependent, the goal of the brief intervention is not to help them moderate their use. The goal of the brief intervention is really oriented towards motivating them to engage in community-based services. Now, we believe that our model is, and I think the SBIRT model, and certainly the motivational interviewing model is, you cannot treat an empty chair. And so we never make demands on our patients. We don't label them. We don't judge them. What we say is, Mary, based on your score, it appears that you might benefit from some additional support. Is that something that you might be interested in, or is there a way or can we talk about that for a minute? And Mary'd say, well, sure. And we'd say, well, can I talk to you about some resources that might be available if you are interested? Well, sure. And then we might talk about community care. But we would not preclude them from coming back to see our providers for brief therapy, because recognizing that if I can see the patient, I might be able to make a difference. And perhaps that patient comes back and sees me for brief therapy a time or two, and then they say, you know, Steve, let's talk some more about that other treatment you talked about, or tell me more about AA, or tell me more about Narcotics Anonymous. And so the whole idea here is that we want the patient to engage at some level, because I can't help them if they don't engage. And so we would really bend over backwards if a brief intervention patient wanted to come to brief therapy, we were happy to do that. If a brief therapy patient wanted to go to treatment, that would be fine. If a treatment patient would only settle for a BI, then that's what we did. But we really work to try to engage the patient at their level of willingness to engage, rather than making demands. You know, Mary, you need treatment. I can't really help you. Go see Bob at the treatment center. And then we never see Mary again. So rather than making those demands, we took a completely different approach, which would be, what would you like to do about this, Mary? And is there any way I can help you? And if Mary was using 1 gram of cocaine a day, and she said, you know, I'd like to cut my cocaine use in half, we would go, you know, Mary, that's fantastic. Can we work together to try and make that happen? And then we would work with Mary to cut her cocaine use in half. Is it perfect? No. Do we support cocaine use? Of course not. But do we recognize that the patient will make their own choices? Absolutely. Do we recognize that we're much more likely to be able to help them if we can keep them engaged? Absolutely. And do we also take a more pragmatic approach that says 1/2 gram of cocaine a day is 50% better than a full gram of cocaine a day. And recognizing that if Mary comes back to see us, that maybe the next time she comes back, she says, you know, Steve, I'm down to that half a gram a day, and, you know, it wasn't really fun. I didn't really enjoy it that much, but I sure feel a lot better. Maybe I'll cut it to a quarter gram a day. And so recognizing that change is a process. In fact, just for 10 seconds, think about something in your life that you would like to change. Could be anything: diet, exercise, smoking, calling your kids more, showing up for work on time, anything. Think about something you would like to change from it. Now, think about how long you've thought about changing it. Has it been years, months, weeks? I'll bet it wasn't something you just thought about changing today and you made a change. Change is difficult. It's difficult for everybody and certainly difficult for our patients. But what we recognize in this model is if I can engage the patient, their likelihood of change goes up dramatically than if I don't engage them. And so any way I can engage the patient and any way I can use what they give me. So if they want to cut their cocaine use in half, I will support that. Why wouldn't I? It's a move in a positive direction. And we all learned in high school physics that an object in motion tends to stay in motion. And so our goal is to engage that patient, get them moving in a more positive direction. And as they feel more self-efficacious, as their health improves, as they feel better, as they spend less money, they start to see the benefits of that change, and they want more of it. And so that's really been our model. So we're not, certainly not wildly successful engaging people in higher levels of care, but I think we at least offer it and make it palatable.
Okay, I've got 3 more questions, one and then a 2-parter, and then we can get back to your presentation.
Okay.
Do patients return to the emergency department for the intervention sessions?
Yeah, when we did brief therapy, what we would do is we would say, so Mary, you know, you're going to come back and see me. You know, I've scheduled you an appointment for Tuesday at 3. Here's my card. When you come in, just tell them you're here to see me. And so it's just like them, you know, coming back to get a follow-up or have stitches removed or whatever. They just would come in and say, yeah, I'm here to see, you know, Mary Smith. And they'd say, great, we'll get Mary for you. So it was just that standard sort of thing. And yes, they would directly come back and see usually the same provider that they saw originally. And again, part of what happens in that model is the provider has already built some rapport with the patient. And so they can really take off from where they left off at the brief intervention and pick up in that more of a private counseling session that's a little bit longer, but still based on MI and still based on health behavior change around substance use.
Okay. For full screen patients, do you use sorry, do you use the assist or the audit? And about how many minutes does your brief treatment sessions take?
Well, excellent question. From a time perspective, the pre-screen takes about 30 seconds. It's those single question screens that we discussed earlier. The full screen, depending on how sort of harmfully involved the patient is, usually takes from 2 to 5 minutes. If you do both the audit and the DASC, you're probably looking closer to 5 minutes. If you're doing just one or the other, probably closer to 2 minutes, 2 to 3 minutes. So they're very time limited. Our brief interventions, and if we take the GIPRA out of it, our brief interventions generally between 10 and 20 minutes, usually right around 15, but they could be briefer than that. If you're doing a referral to treatment and the patient actually says, I'm willing to engage, clearly there's going to be some more time there, but certainly not over half an hour for the entire process. And this of course, is not including the GIPRA. If we're talking about the GIPRA, then you're going to add, you know, significant amounts of time depending on what sessions of the GIPRA you're doing, how fluent your provider is in asking and getting through those questions. All of those things become are in play when we're talking about the GIPRA questions. But by and large, your pre-screen should take about 30 seconds. Your full screen somewhere between 2 to 5 minutes. And I like brief interventions. If I do a brief intervention, I try to do it in 10 minutes. I know that sounds like those of us who are used to doing longer term kinds of therapy think, well, what can I do in 10 minutes? It's amazing what you can do in 10 minutes. I mean, it really is remarkable, and it sounds almost too good to be true. As far as brief treatment, the brief treatment sessions would usually be 45 to 50 minutes, and basically it's a longer brief intervention where you have more time to investigate, you know, what's going on with the patient and talk about menu of options for change and things like that. So pre-screen, 30 seconds, full screen, 2 to 5 minutes, brief intervention, 10 to 20 minutes.
Okay, thanks so much, Steve. That's it for the questions.
Okay, great. Well, thanks, guys. That was great. I appreciate all those questions. And so we'll go ahead and move forward here. Let's talk about some results. The big question is does what we do matter? And so my question is, does SBIRT lead to health behavior change? And again, from our focus that we are talking about substance use as a health-related behavior, you notice I didn't say does SBIRT lead to reduced substance use. Clearly, that's the health behavior change we're looking at, but we want to talk about the broad sort of umbrella of health behavior change, and so because that really is the business that we're in. So does SBIRT lead to health behavior change? Let's look at some numbers. In our project, we provided screening and feedback to 150,452 patients. That's a lot of folks. We did a brief intervention on 23,000 patients, brief treatment with 2,900 patients, and referred 3,000 patients to treatment. Now, this is the score breakout. This is not necessarily what the patient received. And in fact, all of the patients that are brief intervention, brief treatment, or referral to treatment would have got a brief intervention. Some of the patients that of this almost 3,000 came back to brief treatment. Most of them didn't. Some of these patients that were referred to treatment went to treatment and were engaged. Some didn't. In fact, most didn't. But you can see, so we saw a total of 177,000, almost 178,000 patients in our 5-year process, 5-year project, and actually most of the first year we didn't see anyone. So really, it's almost 4 years. We did something that hadn't been done by any other SBIRT state that I'm aware of, any other grantee state, is before we started providing interventions to people, we just started screening people. And so you can see that we screened and did follow-up with about 1,700 patients. These are patients that merely got the screen, did not get any kind of intervention. We just asked them the questions, recorded their scores. And they serve as our control group. And you can see that the control group, the intervention group, pretty consistent. You can see education, you know, almost 12 years, age exactly the same. The breakout of female to male, fairly consistent, you know, 5%. Most of our patients, you can see, were African American. Only a third were employed. There's the unstable housing or precarious housing, 39 to 45%. In wages, you can see they were certainly on the lower income scales. So that gives you an idea of the patient population. But the control sample and the intervention group were fairly consistent. So the control group again received screening but no brief intervention. And then we completed 6-month follow-up on 50% of the control group and 65% of the intervention group, which is actually fairly good. So did anything good happen? Well, what we found is, and you can see the intervention group is our red line group here, and our control group is our black dotted line, that the intervention group was 46% more likely than the control group to report moderate and high frequent drinking at follow-up. In other words, you can see that at follow-up, they started pretty close when they talked about their drinking frequency. 77% to 74%. That's where they started. That about around 75% of both groups were in the moderate or high risk range when we gave them the screen. 6 months later, the folks who got a brief intervention, as you can see, significantly reduced their use compared to the non-interventional or the control group. So 1 in 4 intervention patients actually reduced their drinking from moderate or high to low frequency compared to 1 in 5 in the control group. And that's fairly relevant. The question, there's a question here that the data begs us to ask, and that is, why does the intervention group, or the control group, excuse me, change at all? We didn't do anything with them except ask them a series of questions. And yet they made some changes. And so one of the things that we need to explore more deeply from a research perspective is, does just asking the questions make a difference? And based on this information, it appears to. Not as big of a difference as an intervention, but it's certainly interesting that just asking the questions may lead to some behavior change and some reduction in use. So I think for those of you who are out in the field, those of you who start new SBIRT projects, things like that, I think this is a wonderful question. Anybody working on a dissertation, this may be a wonderful question for you as well, is just questioning people about behavior enough to motivate them to change that behavior. But clearly our intervention, and all these results are statistically significant as well. So this change is significant, and you can see that's a fairly big change or difference between the control and the intervention group. The intervention went down more steeply and farther than the intervention group. But the question remains, why did the intervention or the control group change at all? Binge drinking days, and again, the intervention is the red line here, and the control group is the black dotted line. You can see they started almost exactly at the same place for number of binge drinking days. We define binge drinking days for men as 5 or more drinks at one sitting. For women, 4 or more drinks at one sitting. So you can see that, again, the control group, apparently just asking the questions leads to some behavior change. But you can see the intervention group actually reduced their number of binge drinking days by over half. Again, SBIRT, I think, moves away from the idealism of the old model that we've used historically in our field, which is you got to be abstinent or it doesn't count. SBIRT, so that's a real idealistic model, and it's a wonderful model, and SBIRT certainly supports abstinence. But not everybody needs to be abstinent, and any change is good change if it's in a positive direction. And so in this case, our patients in that intervention group went from binging almost 8 days a week, 8 days a month, to only binging 3 days a month. Now, is that perfect? No, but we've cut their binge drinking in half. And we did this in 15 to 20 minutes. And I think that that's part of what's really unique and forceful and important about SBIRT and about fidelity to a clinical model and about having well-trained, competent staff providing this intervention, is that people will change, and we can assist them in making those changes in a very short period of time. And that change can be fairly profound. They reduce their binge drinking days over half. How about the number of days they actually drank? Well, again, you can see huge change in just the control group, just from asking the questions. And again, I think that's interesting to question, why did they change? But again, you see the intervention group, they were drinking almost 12 days that they were drinking alcohol a month. So that's what, 3 days a week. They cut that to 6 days, again, in half. And so is it perfect? No. Do some of these people, would abstinence be a better low-risk choice? I'm sure it would be for some of these folks. I don't know. I don't have that data. But for some of these folks, it probably would be. But if we can assist a patient in cutting their substance use, and particularly their drinking, by 50% in 10 or 15 or 20 minutes, that's remarkable. And not only that, but it will have a great impact on their overall health. Increases in abstinence. Did anybody become abstinent? Well, they do. One of the myths that we get from working with that chronic, terribly addicted population that we've had a tendency to focus on in addiction services is that we don't expect that people will just self-select into abstinence. And what we find in SBIRT is that people actually will. Sometimes just new information will lead them to say, you know what, maybe I just won't drink. And so what you see is our intervention patients, more of them were sort of abstinence in the past 30 days anyway, but they went from 13% abstinent in the last 30 days to almost 34%. And you can see, again, change, a fairly large change in the intervention group or the control group as well. Begging the question, why did they change? But they went from 7 days of that 7% were abstinent at baseline for 30 days, and 30%, almost 31% at the end. So again, real significant. And this doesn't mean they're abstinence for life. Doesn't mean they're in recovery. Again, it just means that for the last 30 days they haven't had a drink when before they were. The question came about engagement and treatment. All of our highest risk patients, obviously, we attempted to refer them into the community for traditional care. About 15 to 30% of these patients engaged in treatment within 3 months of receiving our services. And that's well higher than the national estimate. This is not inconsistent with a study that was done in the Washington State SBIRT project when I was there, that showed that at least Medicaid age-blind and disabled patients were about 2 to 3 times more likely to access services, traditional care, if they needed it, if they got SBIRT services first. So we see some impact of SBIRT in assisting patients and motivating patients to engage in higher levels of care. And so you can see that between July and September 2010, it was about 15–16%, and that by January and March of 2011, it was about 32%. I don't have actual research to support this, but anecdotally, I believe this is a result of our providers becoming more proficient with motivational interviewing, and that they were able to assist the patient in accessing their intrinsic motivation and then acting on it. And so, because you see this is a fairly short period of time, from July of 2010 to March of 2011, but there was a significant increase in the number of people that would actually engage in care. And again, I think that is a result of the competency of the staff. Other things also improve. Clearly, substance use can negatively impact mental health. If you're anxious, you're going to be more anxious. If you're depressed, you're going to be more depressed. So what we did is, when at intake, you'll see, again, very consistent between the control group and the intervention group, but the intake scores for just people in the general, adults in the general population, this intake score down here was in the lowest quadrile. So they were in the lowest 25% of the population when they were screened. And as you can see, our brief intervention patients went up, you know, almost to the midpoint there. Their mental health improved, self-reported mental health improved significantly. While you can see that our control patients, and this is one of the few places where it deviates, our control patients, their mental health, they actually reported it as it declined. And so again, this begs some questions. What is it about reducing substance use that improves a person's subjective impression of their mental health status? And then, you know, secondarily, why did these patients' mental health status decline? Why was their sense of their mental health status worse than at baseline? I don't have any information on that. I just think those are some interesting questions to ask. But again, if we talk about SBIRT as health behavior change, clearly when changes are made in substance use, patients report an improvement in their mental health. How about ED utilization? This was just a 1-month sample, 248 SBIRT patients, 170 control patients. What you can see is they were using the ED fairly close here, that they were actually accessing the ED, and I believe this was monthly, you know, so 3.2 days per month or almost 3 days per month. And you can see that our intervention patients actually cut their ED utilization by a third, or by 2/3. A little bit of change in our control group, but not a lot. But again, the intervention patients clearly, and again, anecdotally, I don't have data to support this, but anecdotally, if they are addressing their substance use and their health starts to improve, they don't come to the emergency room as often. In fact, when they come to the emergency room, and maybe why they don't come to the emergency room is because they feel better, not only physically, but they feel better mentally. And so the fact that they feel better leads to less utilization. This was a significant change, by the way. It was statistically significant, even when we controlled for demographics and health-related status. And so what we recognize here is cost savings probably outweigh the cost of services. And again, greater than 60% of our patients were uninsured, 16% were Medicaid. So if you think about this from a cost-benefit perspective, 60% of these patients were basically getting free services, which means that every time they went to the emergency room, it cost the hospital money. And so any reduction in that technically is a cost savings for the facility. And so this is really actually a really dramatic sort of change here in ED utilization that we think is a result of improved health care, an improved sense of mental health, and then a significant potential cost savings here on the backside. So here's some quick conclusions, and I have one more little section of data that I'm going to go through really fast. Yes, SBIRT makes a difference. Yes, they will engage in treatment. And yes, they're going to use services less. Now, just very quickly, I'm going to skip past this part. We also compared an urgent care population with an ED population because we wanted to know, are these populations different? And we did this at our Macon site. So just look at these numbers very quickly. Alcohol use in the last 30 days. For patients who came to the emergency department, they reported about almost 13 days of drinking in the last 30 days. Our urgent care patients, half of that. So clearly there was a difference here. As far as binge drinking days, number of over 5 for men or over 4 for women, our emergency department patients said they were binge drinking 7 days in a month, while our urgent care patient says only 2 days a month. So it's significantly different in use. Okay, look at their cutoff scores. For urgent care, 90% of the patients who were positive on the pre-screen got a brief intervention. Only 6% were brief therapy and only 3% for referral to treatment. So let's compare that to the ED patients. Only 74% of the ED patients compared to that 90% of the urgent care patients got a brief intervention. And look at the increases in acuity here for these score ranges. They went up significantly. So 12.4 and 13.7 compared to 6.1 and 3.1. So a significant increase in acuity between these two sets of patients, the ED patients and the urgent care patients. So here's some quick conclusions. There were significant decreases in mean drinking days at 6 months because we did follow up on these folks. Apparently there was no effect for group membership. Neither of these, either group, there was no particular change here. So that what we found is that doing screening brief intervention in urgent care may not be any more have any more of an impact than just asking the questions. And so clearly this is another area of study that would be very interesting, is just asking the questions in urgent care, not even doing a brief intervention. Is it just as adequate to just ask the questions and call it good? So I believe this brings us to the end. And I think we're right on time. We are. That's my contact information. I am thrilled to have any of you contact me if you have additional questions, or if I can provide any technical support to you, other information. Feel free to give me a call or shoot me an email, and I will get back to you usually within 24 hours, somewhere between 24 hours and 6 weeks, I will get back to you. That was a joke. But quickly, before we close, any other outstanding questions for today?
No other questions have come in, and I'll be sure when I send out the information about where to get this recorded webinar, I'll be sure to include your contact information too. I just want to let everybody know that Steve was talking about GIPRAs, but we actually have our own, and it's only 2 minutes long, and it's really just an evaluation of this training. These forms are very important for us, so about an hour after this webinar, you'll get a link to that survey, and I will send it again tomorrow morning along with a link for the PowerPoints and also the recorded webinar and the CEU order form if you're interested in that. So that'll all be tomorrow. Thank you very much, Steve. I think it was very informative. I'm glad we had so much participation, and I'm sure you'll be getting more questions after this.
Great.
So,
thanks, Christine. Thanks, everybody. I really appreciate it.
Good to see you again. At this time, I'm going to